Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, everyone, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and when your kid falls off the monkey bars or starts limping after soccer practice, how do you know if it's just a bruise or if it's something more? On this episode, we're going to sit down with Dr. Eric Krohn from Monument Health to talk about pediatric orthopedics, the world of growing bones, and joints, and muscles. Kids aren't just small adults when it comes to orthopedic care, and Dr. Krohn is going to help explain why specialized treatment matters for young patients. From sports injuries to birth conditions to growth-related concerns, we're going to break it all down in a way that parents and grandparents that sometimes have to take care can understand too. So, welcome, Dr. Krohn. Thanks for coming in and doing this.
Thanks for having me. I appreciate it.
You bet. Now, I heard we were sitting out in the lobby talking a little bit before we got in here, and you're a Washington native.
I am, yes. Then, originally from Eastern Washington.
How did you? Eastern Washington?
Eastern Washington, yes.
Oh, okay.
The desert side of Washington, yes.
It's like South Dakota. It's like we don't talk about that part of the state.
I would say East River and West River really makes me think of east side of the mountains and west side of the mountains.
I bet it does
Very
for
much
Washington,
so,
doesn't
yeah.
it?
Uh-huh.
So what led you here?
What brought me out here? Yeah. So my mother-in-law, she's originally from Mitchell.
Okay.
And so she has moved out to the Black Hills for, kind of like her retirement home and whatnot. And so she actually had just to get into it, she needed surgery, and she went to Monument Health, and one of the surgeons there helped her. My wife is a general surgeon over at the main hospital.
Excellent.
And so those two got to talking, and then he reached out to my wife, said, "Hey, do you want a job?" And she's like, "Well, my husband's a pediatric orthopedist," and they had already checked with the orthopedics group because our pediatric orthopedist in Rapid City retired about a year before I got here.
Okay.
And so they said, "Yeah, sure." So my wife actually got me this job. So
how long have you been here?
I've been here since October of 2022.
Oh, so you're relatively new.
Relatively new,
okay.
for sure, yeah. And we had a pediatric orthopedist, Dr. Eckridge.
Yeah.
Eckridge, I believe. Eckridge or Eckridge.
That sounds
Yeah, I think
familiar.
It's Eckridge. Up until, I think, 2020 or 2021 when he retired. Yeah.
So were there doctors in your family? Or why did you even pick this profession to begin with?
Yeah, so honestly, it's a lot of things in terms of, just getting into being a physician. When I was trying to figure out what I wanted to do after college, I actually edited someone's book. And in that book, they said, so many people are too afraid of doing something hard. And to be honest with you, that was where I just kind of realized I had always wanted to do it. Really wasn't sure what I wanted to do after college. And that was kind of the epiphany, I guess you would say.
Yeah.
But, just always liked being able to, answer questions and evaluate people in terms of like their anatomy and everything. Anatomy is very interesting to me. Mm-hmm. And so I think that's what also kind of led to orthopedics once I, got into medicine. Because I definitely didn't get into medicine thinking I do orthopedics.
Right, really?
Yeah.
What did you think you might have done?
So I thought, if you ever watch the show Scrubs, I thought I was a JD for sure. And then as I'm going through and realized I liked ortho, you can't really match it up with Turk. So then there's no orthopedist in there, so I guess I was the Todd the whole time and just didn't even know it.
I don't think anybody's ever said they wanted to be
I guess.
Todd.
Well, you meet me
and
then meet him, and you're like, yeah, maybe not so much. But that does fit the best for kind of the cliche orthopedist.
Right, okay.
But yeah, no, so that's I thought I would be doing medicine, and I got interested in surgery. Early on in my rotations, I said, hey, I just should try some surgery. So I did a urology rotation, was like, oh, wow, this is kind of cool, and then tried the different ones out. Didn't really like the gen surge thing, a little bit too much, poop and that kind of stuff.
No,
I love my wife, but
right.
but yeah, orthopedics really set it with me. And then also, when I was younger, I did stuff with partners and pals on kids with, issues with developmental disabilities and that kind of stuff. And so what's funny is that I really didn't think about that being important, but as I went through, I was like, well, I can still help that population out more in the pediatrics, orthopedics side of things. And so that's what kind of led me down to the pediatric side as well.
Well, let's get into this a little bit then.
Yeah.
So a lot of people they hear the word orthopedics, and I think most people have a general knowledge of what that is.
Yes.
But I think the first question that would come into people's mind is what's the difference between pediatric orthopedics and an adult orthopedics.
Yeah. Well, first I just have to say that being a pediatric orthopedist is the word itself is very redundant. So orthopediatrics means to straighten kids. So it's from
I never even thought of that.
Ortho has nothing to do with bone. Same thing with orthodontia has nothing to do with teeth. It just means to straighten teeth. Well, I guess dontia does,
boy,
but
yeah.
So that ortho part just essentially means straighten.
Okay.
It's a little different than that, but that's what it means in that word. And so when someone says there's an orthopedist, it means they're a kid straightener. So I'm a pediatric pediatric kid straightener. Exactly. But really, what my focus is in terms of like fellowship training is more of the deformity and contractures and stuff that can happen with kids with cerebral palsy, scoliosis, hip dysplasia, those kind of issues. Not to say that there isn't some we don't think differently when it comes to fractures. We definitely do, but most orthopedists can handle the basic pediatric injuries that come in.
Right.
In our group we have 2 sports medicine doctors who they're the ones who don't have a pediatric training, but they do the pediatric like ACLs and stuff. So pediatrics doesn't always just mean I do all of the kids.
Right.
It really means I'm the one who does the kids in terms of like their deformity, and then the kids who have a lot of syndromic issues and whatnot, who may have multiple orthopedic issues that we need to like follow. That's really what my specialty training is in, technically. But then when you have the fracture that is maybe it's not missed or the first fix doesn't help, and you're dealing with a much more complex issue, those are the things that come to me as well then. So like a non-union or anything like that where the bone doesn't heal. But it is pretty wide ranging, but it's not as like if someone comes to me and they're a kid and they have an injury, I certainly see them, but there's a chance they might not need my certain subspecialty training. I would still, of course, see them for sure. But yeah.
All right, that's pretty interesting then, because when you're talking about your specialty, that subspecialty of pediatrics, then are there common conditions that you see in your specialty?
So I tend to be, in terms of just quickly going over like fractures and stuff, so a lot of the intra-articular ones that go into the joint, those fractures.
Anti-articular.
Yeah, so is a fracture that goes into the joint. So it doesn't just break like the middle of the bone here.
Yep.
Those aren't as concerning and don't always need as aggressive surgery, especially in kids. But if it's into a joint, kids, even though they can remodel their bones, so their bones change over time, unlike ours just heal in whatever position they're in. Joints don't remodel, and so you need to go in there and you need to line that joint up. So those are things that usually would go to me in terms of the broken bone issues. Tendon and some ligament injuries would come to me as well, but like I said, our ACLs tend to be done by our other 2 providers. But then common conditions that I see are like toe walking, hip dysplasia, so where your hips don't form well. Usually I'm seeing those kids really in infancy and then follow them along. Sometimes I'll see them a little bit older, and then Dr. Milligan and myself will sometimes see them in the adolescent and adult world. Other things like clubfoot, that's a thing that I commonly see.
So you mentioned the toe walking. Explain that briefly.
So toe walking can be from a number of different things. A lot of kids who I see with toe walking have what's called idiopathic toe walking. So they don't have some neuromuscular disorder or something else higher up that's causing them like spasticity in their legs, and that's why they're up. A lot of times these kids actually just like to feel the feeling of being up on their toes. And so that's something that's somewhat hard to control sometimes because you're fighting, the brain. They like to be up on their toes. You put them into a cast for 4 weeks and then take them out. Well, they still like to be up on their toes.
Right.
So that's something that occasionally I'll do surgery for, but I see quite a few people for that and counsel them along and kind of keep telling them, hey, it's okay. We just need to keep doing this. And a lot of times kids get better when they get into their older years because they start to see everyone else around them not toe walking, and they're like, oh, I don't want to be the outlier.
Right.
So they dump their heels down. But sometimes you cast, sometimes you do therapy, sometimes you do surgery. But that is something.
There is a surgery for it too?
So it's really the last line.
Right.
But especially if they have a very tight heel cord, that's the reason they might be toeing down a lot. And if I see these kids who have been toe walking for a while and I can't get the ankle back to 90 degrees anymore, then I start to think about maybe I need to do a release so that we can get that leg up there, so then we can start to break that cycle.
Now, can that be genetic with kids?
So not idiopathic toe walking.
Right.
If it's genetic, then they probably have some type of genetic syndrome, and probably a neuromuscular issue, and so they have another reason why they're toe walking, not just that their anatomy is normal and they like the sensation of kind of being up on their toes.
Now, you mentioned another one you mentioned too was clubfoot, which I think a lot of people have heard the term.
Yes.
But I guess I don't really know what it is.
Well, what it is the foot comes out, and for lack of a term, it kind of looks like a club. If you put your hand kind of in front of you and imagine your wrist coming out from like underneath your thumb, like, and you imagine that's like a club, and that's kind of how the foot comes out.
I see. So it's turned.
So it's turned. Yeah, it's pointed down, it's rotated, and it's turned in like this.
Okay.
And it's a rigid deformity too. Kids can come out with what's called positional, where it's just they're kind of packaged in there tight, and their foot's flexible, and they don't need me. That gets better on their own. But the rigid ones, the actual real club foots, they are actually treated by what's called serial casting. And so you start to cast that foot slowly, week by week, to try and get it back into its normal position. Then you usually do a little operation to help with that toe down position that they have. It's not for toe walking, but it's still that tight heel cord. And then they're in braces for quite a while. And the thing with clubfoot is, recurrences are definitely a problem. But the good news is that the casting is how we treat these days. Ponsetti is the guy who really developed it, and he's actually from Iowa, and a good Midwestern guy too.
Good.
So he developed it, and so that's how we really fix most of these feet, because the major surgery for it, while it's very good at making the foot look straight, it makes it very scarred in. And while sometimes we have to do that big surgery, the casting makes the foot supple and flexible. And most of these kids go on to have fairly normal lives, maybe a little bit difference in terms of the limb length or the size of their foot. But when I'm counseling someone about this and why I'm treating the clubfoot, it's so that kid can get out and can run and play sports and do all of that stuff. Are they going to be an Olympic sprinter? Well, probably not, but I didn't have clubfoot, and I'm definitely not going to be an Olympic sprinter.
Kidding.
But they should still be able to, do activities and enjoy life.
Is it a painful deformity?
So the deformity itself shouldn't be painful, but the reason why you want to correct it is when they start to walk, if that foot's in that position, they're just going to walk on the outside of their foot.
Right.
And that's not a part of the foot that's supposed to be walked on. So especially as they get bigger, then that can lead to skin breakdown and ulcers and that kind of stuff. We don't really see that too much more in this country. Occasionally you might see someone who fell through the cracks, but really neglected clubfoot is what we call it, and that is something that you kind of see more in like medical mission type stuff these days.
Are those like mostly the more common things you see, or what are some other things?
Some other things that I see. Yeah. So we talked about hip dysplasia, scoliosis. The twisting of the spine, a common one that I see, especially in like adolescents, but I also see younger kids for it. Other things than that, cerebral palsy, I see a lot of that, and deal with the various different issues that can happen due to that, whether your kid has very little involvement or significant involvement. It's a very wide-ranging disorder. Things other than that, definitely a lot of breaks, a lot of bumps and bruises. I'm ruining a lot of spring breaks right now by telling people they got to be in cast for the next month and a half.
You didn't ruin anything.
I did not break their bone. Yes, but I am the one who gives the final call. And other than that, I'm sure there's a number of other things that I'm missing right now.
Well, I think those are
good list.
That is, absolutely. Are there things that, as we're talking to parents right now that have kids? A lot of times we do have the mindset as a parent of, it's just you're fine.
Yeah.
You know what I mean?
Rub some dirt on it, right?
Rub some dirt on it. Get up, get out. But are there things that parents really should not wait? When something happens.
So no young kid, and I'm really child from, if you want to define that, up to 18, should be having chronic pain. Now sometimes some kids do, but if you have a kid that's having consistent pain over time, complaining about something, it should at least be evaluated, and we can make sure that alignment is okay and that we're not, don't need an MRI to check for soft tissue. But things that have been lingering around for a long time, especially pain with activity, those are things that would worry me. In terms of more short term, like your injuries, I tend to tell parents that, if something's feeling better in 24 hours, odds are they're going to be okay. But if they're still limping, if they're still hurting, there's a good chance there could be some type of what we call an occult fracture. So we don't actually see it on x-ray. They're just tender on their bones or their growth plate. So occult just means hidden. You can't see it on x-ray.
Right.
And then, but they can also have little buccal fractures, which their bones are more cartilage than ours. So again, using us as an example, when we break, we just shatter, right?
Yes,
but little kids, they can kind of bend a little bit. And the reason why I bring that up is because I have probably at least once every couple of weeks a parent come in and say, I just feel, terrible. I thought they were fine and they had a broken arm this whole time. Well, they didn't have obvious deformity. Their hand wasn't bent backwards.
Right.
It looked normal. They were a little swollen. They were a little tender, and kids heal pretty quick. And sometimes you'll even notice with some of these little breaks, like they fall, they hurt, they're like, it hurts a little bit, and then the next day they seem to be hurting a lot more. So I would say if that pain is persisting, if you see obvious deformity, definitely come and see somebody. But to be honest, if you're just worried, that's kind of what we're there for. I'm almost there a lot for just peace of mind for people to say, yeah, they're okay. There's not a big problem there. We tend to be more aggressive that if someone's hurting a little bit after an injury, I just tend to treat it like a break because I can't always see them on x-ray.
Right.
But 6 weeks in a cast for a kid is no big deal. They'll get all their range of motion back. And it's not something like I put you or I in a cast, an elbow cast, above elbow cast for 4 weeks, and our elbow will probably never get straight again. Whereas I leave kids six to 8 weeks.
What I want to hear.
I know, right? Don't try and avoid a cast on your elbow if you can. Yeah,
that's good advice right there.
Exactly. Yeah.
So there must be enough breaks. Going back to that very common thing that can happen, that you may never. I mean, not never, but you just don't know it's broken.
Yeah.
I mean, that can happen. Obviously, are there bones in the body that are more susceptible to you not knowing?
So that is actually a really good question. I don't know if anyone's ever looked at an incidence of, these bones, you tend to have more occult fractures than other ones. I would say things that I tend to see would be like the top part of the shin bone in really young kids. You can get a break there, in a 2-year-old who's just running around.
And they don't know?
And well, they'll know. They'll have pain, and you'll get an x-ray and you might not see anything, and they're tender, they're wincing, and so you put them in a cast, you bring them back after 4 to 6 weeks, you take an x-ray and you see a healing response. And you're like, oh, okay, that bone there was broken. It's putting down some more bone. And you just you don't really find out about it until then. And that's why when someone has that bone tenderness, you just treat them as a break. I have plenty of patients, and I counsel them when I do this, that they'll come back after 4 to 6 weeks. I'll cut the cast off. I won't see a healing response. They're non-tender. I'm like, I'm not sure if it was broken. It might not be, but you're good to go now.
I hope you got a lot of signatures.
Yes, exactly. Yes. And it's nice because, you're putting them in a cast. You're not saying I'm going to go to surgery and then you're like, oh, wow, that wasn't broken the whole time. A cast, it's just, I think we're more apt to do that because the risks of it are fairly low. It's no fun to be in a cast.
No.
Even the kids that are excited, I tell the parents that everyone likes a cast for the first 3 hours. And then after that, it's
once the itching starts,
it's all downhill. Yeah. If you ever have a kid who's itching in a cast, get a blow dryer on cool or an air compressor, hit it from the top or the bottom. That pushes along the air along the skin and can give it a little sensation of itching. It's not as good as getting your hand down there, but it's a heck of a lot better than a wire or something, a coat hanger or something.
Well, I haven't seen that on TikTok. Then that's there you go.
Well, I need to go and do that.
You should.
Then.
You know how viral you would be by telling people to do that.
My nurse has one. She's the one who tells everybody that now. So she's the one who gave me the air compressor idea. I knew about the blow dryer. She was the one who mentioned the air compressor.
That's brilliant, though.
Yeah, most definitely. Yeah.
What a great idea.
Yeah.
Okay.
And I'm seeing less pens and money in casts these days.
There?
So yeah, hopefully it's helping.
What is the do you have any memorable thing that's come with somebody in a cast?
In terms of funny stuff,
right?
I have money is probably the thing I see the most because I don't like change.
Yeah.
Because they're not putting it in there because they're itching. They're putting it in there because they're bored.
Yeah,
something to do. So I jokingly will tell kids that if I cut the cast off and they find any money in there, that's a tip for me, right?
Of course it is.
But really nothing too strange. Pens, Q-tips.
I suppose.
I have had a few patients, and these were adults actually, who have come in and you take the cast off and they've got pen marks all down their arm. And you're like, so are you scratching? Oh, no, doc. Oh, no. It's like, oh, that ink just came from nowhere. Right. I actually have never had a kid come in with the pen marks.
Yeah.
So it's only been adults who have
they
done
leave
that,
the cap on. They're obviously
well, exactly.
Smarter
they're not putting the ink cart down. Yeah.
Do you have, especially, when kids get to this summer, as we head into summertime?
Most definitely. It's already starting. Yeah.
And everybody's going to be outside. And everybody's going to be doing, things that we only get to do 3 months out of the year.
Yes, exactly, right?
I mean, if you could tell parents, one thing, what would you tell them when their kids are out?
If they're able to put weight on it, and and you don't see an obvious deformity, it's okay to wait a little bit to see if they're painful. And then if you come in and find it's a break, don't feel like you're a bad parent. That's okay. That's the one that might get better in a little while. In terms of other things, if they're really hurting after a day or two, if they're having a lot of pain, I would not wait. I mean, a small growth plate injury might not show like an obvious deformity when you're looking at a wrist. And this only has happened occasionally, but where people kind of look at one side compared to the other, like, I think it's just swollen, but they were hurting a lot. Broken bones that need to be fixed with surgery usually hurt quite a bit.
Well, yeah, for sure.
So I would say it's really just if they're hurting a lot, you don't got to wait. Bring them on in. But if they're able to put put a little weight on their foot or they're able to use their hand, chances are it's probably not anything too bad, even if it ends up being a break. And it's probably one of those things that 100 years ago we would never have treated.
Right.
The kid would have gotten better in about 8 to or 10 to 20 days, and you would have never had an x-ray, and they, because of how quickly they heal, they would have just been back to the world.
Right.
But this day and age, we do protect things because, well, if it's a minor break, we don't want you doing everything, and then you go and fall again and turn it into a major break that then we have to fix. So
what is the when it comes to like what's the worst bone in your body you can break?
Ooh, that is a good question.
Is there? It seems leg to me. But
leg is tough, because even if we're treating that without, especially if we're treating it without surgery, like it's kind of around the knee, I might put a long leg cast on, and that's not fun. But little kids who have femur breaks that are higher up, I put them in a half body cast called a spica cast. So some people might say that's the worst one because then the parents have to deal with a kid with a cast, but they didn't need surgery, So
right.
I would say the thing that worries me the most is not so much bone, but if it actually goes into the joint. Breaks into the joint, those are, even kids, they just don't heal like adult, or they just don't heal like they do with their other breaks.
Why? I mean, what's the deal with a bone going, so your joints are like where?
Your joints, you've got your elbow, you've got your wrist, your shoulder, your knee, hip, ankle, finger joints, all that kind of stuff, and it's got the smooth articular cartilage on either side. That cartilage was formed when you were born, and it was pretty much in its shape when you're formed early on in the womb.
Yeah.
But when kids' bones break and they break away from joints, how the body remodels the bone over time, so the body can sense how much weight is going on certain sides, which direction the force is coming through the bone, and it can lay down more bone in certain areas and take bone away from other areas. And as you're growing too, your bone starts out pretty small, and as that grows and grows, the body can do the same thing of putting down bone where it needs to, where it feels the forces, and less where it doesn't, and that actually leads to bones that are crooked actually straightening out over time. So like under the age of 10, there's a lot of breaks that what we call our tolerances. So when I look at an x-ray and say, oh, that has too much of a deformity to it, I need to do surgery, those are a lot higher in those younger kids than in the older kids, because we've seen that they just can heal and fix. I mean, if you have a wrist broken in a 6-year-old and the piece is sitting up on top of the other one and shortened less than a centimeter, you can just leave that there and the bone will fuse together and it'll straighten out, and you'll get an x-ray a couple years down the line and it'll look just like it should have without the break. Joints, however, can't do that. Joints are just their shape. They'll get bigger as the kid grows, but the actual surface isn't able to remodel and change. So that Teflon-coated surface, if it's disrupted by a lot, the only way to fix it is surgery, looking at it, putting it back into place. The breaks higher up that, started and propagated maybe into the joint, those will remodel just like their other things would, but the joint itself just cannot. And that has to do with how the bones are growing. They're growing from the growth plate, which is behind the joint, and they're growing from around the bone itself to make it wider, but there's not growth inside the joint. The joint itself is getting bigger, but it's not really growing out. So since it's not really changing in that regard, the body can't take cartilage away from somewhere and put cartilage down in another area.
I see why.
Bones.
Okay. Yeah. Well, because I've heard doctors or orthopedics or surgeons that'll say things like, sometimes it's better to break your ankle than to sprain it.
Yes.
Is that true?
So there is some truth to that.
Yeah.
In terms of, if you tear a ligament, your body can only repair ligaments with scar. We like to say in orthopedics that bone is the best tissue because bone is the only tissue in the body. I think so. There's going to be another specialty coming after me, I'm sure. But that regenerates with its own tissue. So I cut myself deep enough that it goes through the dermis on the skin. I get a scar, right? When bone heals, it heals with more bone. Even though you might be able to see the bone has kind of like a pocket of bone is built around it.
Right.
That's all still bone. If I took a biopsy of it, it looks like bone. If I took a biopsy of your scar, it would look like scar tissue.
Right.
And scar tissue is just never as good as our native tissues. It can do okay, but so after you sprain an ankle, for that ligament to heal, scar is what's forming. It's not new ligament tissue.
Right.
So when you break, especially if you break and you've broken it to the point where you don't have anything moved and you don't need surgery, then the bone gets to heal the bone. And so it can actually heal with bone. And so it doesn't have scar in there anymore. So that's where that comes from.
Okay.
Is it better? I don't know. I've sprained my ankle plenty of times. I've been up and walking before 6 weeks.
Really?
If an adult breaks their ankle, a lot of times we're not letting them put weight down on it for 6 weeks, depending on the type of break.
Oh, that's super. super interesting. I mean, that's I learned a lot just from that question. Are there things that you get excited about as you move forward in this profession that you think will start to change how we fix
like new
kids,
things that
adults?
are coming through?
Yeah.
There are a lot of things that keep coming up in the adult world. In the kids world, I would say it's a little bit slow growing. We tend to find out more, oh, this was something we needed to do something on, or oh, this was something we didn't need to do something on. I mean, we talked about clubfoot casting and the fact that, casting is now the way we treat these. That's been a huge change in how these kids are, going on and living. But that's really hasn't, started in my career. I'd say the things that I've been hearing about now are, different ways so we can adjust the growth of growth plates to help with certain deformities. And there have been some advances in how we do that and what we can do with that in kids with like cerebral palsy and stuff. We can now do some growing things around their hips instead of just more aggressive surgery like cutting bones and changing positions. There's also been some things, and this is something that I'm getting new into myself, but bioabsorbable screws for certain fractures. So you have a break in your elbow and you're an older kid. Sometimes it's better fixed with a screw than a pin. And the problem is we don't really like to leave screws and hardware around in young kids because just like a bike that's been sitting against a tree for 50 years and it grows around it, the hardware can get overgrown by the bone. And especially then if you're the kind of person who ends up breaking that bone again when you're like 35 and then having that buried metal in there, makes for a tough problem for that surgeon. Don't want that to happen to anybody. But so these bioabsorbable screws, what they do is they have a similar strength as the actual screw going in, but the body recognizes them as something similar to bone, and so they can start to remodel and change that back into bone, and eventually the screw is just gone, and bone fills back in, so you don't have to go back and take those out. So that's probably one of the newer things that's come out in peds ortho.
And I'll see quite frequently different types of casts.
Yes.
That are supposedly being are any of those legitimate?
So, there's probably a lot of stuff on social media, saying, hey, this is a cool thing. Most of that stuff is probably going to be more like a real acute care.
Okay.
Like, oh, this is a quick, cast that you can make and put on somebody. I think of that more of like in the field. Like you need to make sure someone's stabilized to get them back. If I'm putting a cast on someone that it's like a buccal fracture, a break that hasn't really moved, something like that, like I said, probably 100 years ago, we wouldn't have even really treated that. So any of those things would probably just be fine to fixing them. But if it's a break that I have to manipulate to get it back into the position that I want it in, I'm going to probably go for something relatively old school and wrap the cast myself and put a fiberglass or a plaster cast on and mold that. The problem with a lot of those prefabbed things or kind of one size fits all is there's no real molding capabilities. It might do good at stabilizing it, but it's essentially just a splint at that point.
That makes sense.
And I have heard about these things a little bit, but I unfortunately I'm not the one on TikTok, so I'm not always seeing these things, but I look over my wife's shoulder sometimes and just get pulled in. But
I'm surprised she just doesn't send it to you. Like, can you believe this?
No, well, there are plenty of those. That yes, I'll get those for sure, definitely.
What is, according to you, Doctor? What's the most rewarding part of what you do?
When people can get back to what they want to do. Okay. That's the thing. I mean, if it doesn't really matter their age, what they're coming in for. The reason they're seeing me is because they're just not able to do what they want to do, and it might just be that, the parents are hearing them complain about the hip pain all the time and they can't take their walks. Well, that's something that, needs to be evaluated. When you can get them back to the point where they're doing what they want to do again, that's what makes you feel really good.
Yeah, I suppose it does.
Yes,
I mean, that's got to be nice to see an end result.
Yes.
Yes. Absolutely.
Then again, I should say one other thing, that one reason I went into pediatric orthopedics is I really like to tell people they don't need surgery. And in pediatric orthopedics, a lot of times you get to tell them, they come and see me, they're like, we're seeing a surgeon. And the joke in orthopedics is that if you go into pediatrics, you do it because you don't like to operate. There's a lot of non-operative stuff, but that's very nice. Someone comes in, especially when they've got a break that it had to get pushed on in the ER, it was a kind of a tough fall, the kid was shooken up. And then you get some x-rays and you're like, yeah, it's a little off, but he's 8. He'll be fine. It'll just heal in and
oh man,
we'll
that's
be
every
good.
Parent's dream right there is just to hear you say that.
Exactly. I wish I could say that was everyone.
Well, of course.
But it definitely happens a lot more in my office than some of the other offices.
It's been a lot of fun talking to you, Doctor.
Yes, indeed,
I'm so glad you came in and did this for
Happy
this
to be here.
podcast. And anytime you want to come in and even drill down a little deeper on things that you guys do in your profession, that you wish people knew more about, let's absolutely sit down and talk about it, because
we can talk about riding lawnmowers next time.
Okay.
So I guess my one
do this weekend. Come on.
Well, no. So my one PSA.
Okay.
And this is,
let's get it
I jumped on trampolines. I did all that stuff when I was a kid. People will. I'm talking to an orthopedist and I'm saying I'm going to buy a trampoline. The one thing I'd say is, if you have a riding lawnmower, just realize that the only time it shuts off is if you fall off it. If you're holding your kid and that kid falls off, that lawnmower does not shut off.
There we go.
And while it's happens thousands of times in every city, every season, and people are just fine, I'm the one who sees it when it's not fine.
Oh boy.
And yes. So
God, that's a great way to end this, honestly.
Yes, that's my PSA. Trampolines, helmets, that kind of stuff, okay, but riding lawnmowers are
good. I got an 18-year-old. He's not going to sit on my lap on it anymore.
Exactly.
So
as long as they're just not sitting on your lap, you're fine. Go for it. Yes.
Dr. Eric Krohn is an orthopedic. You are an orthopedic surgeon.
Oh yes, 100%. Yes,
100%.
Orthopedic surgeon, just pediatric subspecialty training. All right. So I did an extra year in that.
You've been here about 3 years.
About 3 years now. Yeah.
You've lived through some winters so far.
Yes.
You've survived. So you plan on staying, I'm hoping.
I do indeed. My wife and I did a lot of landscaping in our house, and I didn't do that with the hope that we'd be selling it. Like I said, mother-in-law's here, wife likes the place here.
Excellent.
And I did my med school in Erie, Pennsylvania, so snow doesn't scare me.
Yeah, well, that's fair enough. Dr. Eric Krohn from Monument Health, thank you for coming in, Doctor.
Thanks
I appreciate
for having
it.
me. I appreciate it.